wonderful. We have a wonderful presentation for you coming up. We have three of our esteemed colleagues from the Sylvia Rattel HIV STD Prevention Center with us this morning. Two of whom you probably remember from last year's program. We have Dr. Katherine Shu, who is the medical director of the Division of STD Prevention and HIV/AIDS Surveillance with the Massachusetts Department of Public Health. She's the director of the Rattel STD/HIV Prevention Center Training Center. She is also professor of pediatrics and attending physician in pediatric infectious diseases at Boston University Medical Center. Dr. Shu's research interests include vaccine preventable diseases and prevention of sexually transmitted infections. We also have Dr. Zoon Wangu, who is associate professor of pediatrics at the UMass Chan Medical School and attending physician in pediatric infectious diseases and immunology at UMass Memorial Children's Medical Center in Worcester, Mass. She also serves as clinical faculty at the Rattel Prevention Center. And Dr. Wangu's clinical and research interests include HIV post-exposure and pre-exposure prophylaxis and STI care in adolescents, pharmacy collaboration to optimize EPT implementation, and long-term outcomes of congenital syphilis infection and exposure. And we also have Dr. Amit Achhra, who you just saw for our wonderful MPOX presentation. So without further ado, I am going to welcome them to start their presentation for Vexing Cases, which is going to be an interactive session where they'll be presenting some case studies, and hopefully we'll have some good participant discussion. So please take it away. Thanks.
Great, thank you. So I'm going to be pulling up my slides. Dr. Achhra and I will alternate in presenting the cases. If you have any questions or comments during the presentation, you can either shout them out, put them in the chat, which Linda will be monitoring. And Dr. Shu will definitely pipe in with her additional comments and expertise. And if I happen to fully lose my voice, Dr. Achhra has kindly offered to take over, but at least I can advance the slides. But let's see how far I get. All right. Okay, so let's get started. We don't have any disclosures today. So one thing, I always like to start my presentations with an aside on definitions. And I think most of you in the audience are probably comfortable with this, but some may still be thinking about this when they see patients. So we always present the data that patients most affected by STIs like infectious syphilis, gonorrhea, are primarily MSM, or men who have sex with men. But what are we really describing when we say MSM? So you'll see us use it frequently as a clinical definition. You will see it in the STI treatment guidelines. But when you look at it in terms of references, when studies are done, this term can vary on the patients that are included. Are these transgender men and women on the basis of whether, are the men defined by sex at birth or current gender identity? So that's important to see. And do we have more accurate terms or better acronyms? I still struggle with this. For example, individuals with phalluses, individuals with vaginas and cervixes. Is there a better acronym we can use to describe our patients more accurately that informs their care in a supportive way? So you'll see me use a couple terms in the talk. If anyone has better ideas, I would love to hear them because I'm still thinking about this too. All right, so we have a couple of cases. We'll just go in order so that Dr. Achhra and I can alternate. So with my pediatric and adolescent background, we're going to get started with a 17-year-old. Some of these cases, those of you who attended the prior session in 2021, I think might remember these, but all of them have a little bit of a twist. So the chief complaint here is abdominal pain. So we have a 17-year-old cisgender female. She has nausea and abdominal pain, no other symptoms, and she just blurts out, "I'm not having sex," which all of you who work with adolescents know she 100% is. So she has some constipation, ADHD. She does have a history of PTSD. She's not taking any medications. She does have a history of hives with both amoxicillin and cephalexin. And on exam, she has a fever, some hypogastric tenderness when you palpate her abdomen deeply. You do a pelvic exam. She has some purulence from the endocervix and some cervical motion tenderness. AMSL's negative, and your NATs are pending at the visit. Quick recap for those of you who may not see as many patients with vaginas or cervixes. AMSL's criteria are used for diagnosis of BV, and at least 3 of these criteria get you a sensitivity of over 90%. Specificity is also quite good. But in this case, she does not actually fulfill AMSL's criteria, so you don't get the sense that BV is part of it, and therefore an obvious anaerobic infection is not present. So kind of retain that for the rest of the case. So which antibiotic regimen would you all choose? You've sent your testing, your patient is in front of you with these symptoms. Remember, she does have a history of hives with cephalexin and amoxicillin. What would you like to do? So you can shout it out, put it in the chat, which option seems helpful. Is this a shy bunch? I know this is not a shy bunch.
Okay, so we have B, ceftriaxone and doxycycline, and C, ceftriaxone, doxycycline, and metronidazole.
Mm-hmm.
Dr. Shu wants to know if everybody needs more caffeine.
Yeah.
And
If
we
it
have,
wasn't in person, we could keep.
I
coffee.
know. So we have another E. We have one for B. So it looks like we have B twice.
Okay.
Some
So
distribution.
kind of B, C, E are the options so far. So people aren't feeling like you must admit this patient. And certainly the age has something to do with it. So that's great. So let's move on. Because you'll notice in many of these questions, I do not have a right answer circled because we have some creativity. We're using our clinical creativity. So adolescent STI burden, those of us who see and care for adolescents, we know that a lot of them are at increased exposure for STIs. And there are several factors increasing exposure when they're in this age range, which are listed here. And so the other thing that increases their susceptibility to STIs is sort of a two-headed beast. So one is biological susceptibility. Adolescents with cervixes have something called cervical ectopy or ectropion. So it's a different type of cervical epithelium. In adults with cervixes, this epithelium is multi-layered squamous compared to single-layered columnar. So, what does that do? The single-layered columnar may actually be associated with increased risk of acquiring chlamydia and gonorrhea, plus less estrogen. There's not a lot of lubrication, so more trauma, microtrauma, and also thinner cervical mucus. The other head of the beast is then cognitive and behavioral susceptibility. So this is a very unique stage of development, especially our patient is 17. So they have this myth of invulnerability. I can jump out the window and I will absolutely fly. Limited knowledge, concern about discussing these things with guardians, and then period of increased mental health issues and substance abuse. So all of this contributes to a perfect storm. In terms of regimens for PID, so how are we going to think about treating these patients? So these are the recommendations for 2015. So recall that metronidazole had a little bit of an asterisk because we know that cephalosporins, the third generation ones, they really don't have broad anaerobic coverage. So until studies were done that showed we didn't need metronidazole, or the outcomes for patients who got metronidazole or didn't, if they did not differ long-term, then you wouldn't have to use metronidazole. But that question had not been answered yet at this point. So the point was to consider metronidazole. And so you might think, well, at that time, if we were in 2015, this patient had negative Amsel's criteria, we can't see any obvious evidence of anaerobic infection, we may consider not using metronidazole. This was a study, and I believe I presented this last time, but just a reminder, a study in 2020 of cis women 15 to 40 with acute PID to see, do we need metronidazole, do we not? And so based on the primary and additional outcomes, it was found that in the group that received not only ceftriaxone and doxycycline, but also metronidazole, the researchers less frequently recovered anaerobic organisms. The patients had less tenderness. Interestingly, decreased amounts of cervical MGen, decreased probability of isolating cervical MGen. We'll talk about MGen in a bit. So it became part of, and the age is important as well. We can still extrapolate to our patient a bit, but metronidazole should be given routinely for acute PID. So despite the fact that she had no clear evidence of anaerobic involvement, you would want to give this patient metronidazole. So current options, IM or oral versus completely parenteral. Let's say if she had very high fevers, could not tolerate PO, and you felt like you needed to admit her, you can give all of these things IV instead. So there is some flexibility. Options for beta-lactam allergy, and I ordered these cases. We'll talk about how to approach patients who express, I have an allergy to something, in a little bit. But briefly, if you believe it's a true allergy, a type 1 IgE-mediated hypersensitivity, these are some options. So let's say this patient said, I was given amoxicillin and or cephalexin and or some ceph something, which often my patients will say they can't remember which one. So you can't even count on, I'm safe with a third generation. These are some options. So levofloxacin once daily, metronidazole combination. So some of you had thought about that one, or moxifloxacin. If you feel like your patient needs to be admitted, you can also do a combination of IV azithro, followed by the PO version, or in combination with metronidazole. So there are a couple of options if you are concerned for a true allergy. So back to this case, her other testing is unremarkable, but your NATs are positive for chlamydia. So what can you do for her partner? And you'll remember at the last, for those of you who were here at the prior conference in 2021, we did a panel on EPT and discussed this a little bit more in detail. But just a reminder, for expedited partner therapy, which is the practice of treating the partners, the sex partners of patients that you diagnose with chlamydia or gonorrhea, for example, you can give a prescription or medication to the patient for the partner without seeing the partner. You can go to the CDC website in case you move to a different state in the future. You can always look and see, first of all, is EPT legal? Am I covered if I give EPT, if I prescribe EPT? And then for which STIs can I give EPT? So that's going to be helpful to keep as a resource. Just a reminder too that the data on which the data that we use to support giving EPT, this is from 2005, standard versus expedited care. So the patient treated versus both the patient and partner treated. This was based on giving actual medication to the patient to give to their partner. Personally, what I do, and probably what many of you do, is you may prescribe or give the patient a prescription to give to their partner instead. The data is really based on medications in hand, and that's what really showed the efficacy. So based on that, there were reductions, notable reductions in chlamydia, but particularly gonorrhea. So the important thing here is, these are the guidelines for whom you can treat and what you're going to use, doxycycline, or for gonorrhea, ceftriaxone or cefixime. In Massachusetts, we are only able to give EPT for chlamydia. One point that's not applicable to the patient in the case, because she is a cis female, but an important change in 2021, recall that prior to 2021, there was really no evidence. Well, if you look at the treatment guidelines, they really did not recommend giving EPT for MSM. Data were limited. So the concern at that point was that the partners of MSM who are cis male or trans female, they might have other STIs or HIV that you'd be missing. But we know now, based on a couple of studies, that the frequency of STI and HIV varies in the population depending on which population you look at. And so now the treatment guidelines say that you can absolutely consider EPT for MSM as long as you discuss risk versus benefits with your patient. And of course, if the partner wants to come in and see you, all the better, but we know in many cases that doesn't happen. And then, test for other STIs and always talk about PrEP. So that's a notable change in the guidelines. We do have updated data on efficacy of prescription-based EPT because, as I said, the original studies were done with patient-delivered partner therapy or actual medication. So I believe I might have shared this last time, but for those of you who weren't there, there was a very interesting study in 2020 looking at several clinical sites that gave patients vouchers for azithromycin. So this was for EPT. Not even half were redeemed. So again, this was free medication, come in, pick up your meds, no copay. And for especially the adolescent population, only 30% of those under 18 came by to pick up the medication. So whenever possible, EPT should be provided as drug in hand. And when we did our EPT panel previously, we sort of emphasized that, collaboration with prescribers, pharmacy colleagues, clinic and hospital leadership, that's really important to work together to hopefully move closer to the medication in hand rather than prescription-based. So let's say we get back to the case. You see this patient a couple months after her diagnosis. She took her treatment. Let's say you picked the fluoroquinolone metronidazole combo. She did well, no symptoms. She does have a new partner in the last 3 months. She's had some unprotected vaginal and oral exposures, but she's entirely asymptomatic. So she looks well. So not talking about serology, so we probably would send HIV and syphilis testing, but if we just focus on non-serologic diagnostics, what would people get in this case? So unprotected oral and vaginal exposures and no symptoms in this patient. Vote now.
We have C, oral and vaginal swabs for gonorrhea and chlamydia nat. Another vote for C. Another vote for C. C again.
Great. So I agree with all of you. No need to get an oral swab for gonorrhea culture at this point. And we do want to swab any potentially exposed location. So repeat testing after an STI, this hasn't changed too much over time. So for cis women, trans men with chlamydia, gonorrhea, or trich, 3 months after treatment, Separate recommendation for pregnant persons. We are extra careful with them. They get a test of cure. And then for cis men, trans women with GC or chlamydia, rescreen 3 months after treatment, not enough data to support trick rescreening. That doesn't mean you can't do it. There is just not enough data to support that recommendation. Have I done it? Absolutely. Patients diagnosed with syphilis, with HIV, there's sort of a separate follow-up process and frequency. And then, of course, like we said, HIV testing always if your patient is exposed, and PrEP as well. Extragenital screening, we wanted to review this briefly. So what changed in 2021 regarding extragenital screening, before this, it was really, the focus was on MSM for the screening. So for individuals with cervixes and vaginas, routine screening once a year if they're having sex and they're under 25, like our patient. And you can always now consider rectal and pharyngeal testing. And this is a very specific recommendation in the treatment guidelines based on, where the patient is exposed. I will say we don't quite know, if you sort of are thinking about chlamydia for our patient, because that's what she had, we don't quite know the full role of chlamydia in the oropharynx. We know it's transmittable. Is it particularly virulent? No. Patients can actually clear chlamydia in the oropharynx. They can clear gonorrhea in the oropharynx. But our focus is really on transmission and making sure we decrease exposure of partners as well. And really no changes to chlamydia and gonorrhea in individuals with phalluses. So a little bit more on this case. The NAT was negative, but the lab actually reports a positive result for Mycoplasma genitalium, even though you didn't order it. And I know this is everyone's favorite scenario, including mine, because now you have to deal with TMI. So let's review kind of what should we do with this data that we didn't want. So what are you going to do next? Yes, Kathy.
Just monitoring the chat. I'm not sure you can with your screens right now. There was a nice question coming in about, sorry if I'm butchering the pronunciation, Sari Burke, who said, I provide EPT in a high school, a school-based health center. I document the partner's name and date of birth. Should I also document allergies? And before you move on to other topics, I just wanted to cover that great EPT implementation question.
Sure, thank you. So it's very specific to the state, because what we do in Massachusetts is different than what you would do in Connecticut. And I remember, I think Rayanne providing some very specific, detailed, terrific EPT guidance for Connecticut specifically. I don't know if Rayanne is on today, but I may defer to my Connecticut colleagues about that specific question, because in Massachusetts, what we would do is write a prescription under the patient's name and list expedited partner therapy. That's all we need to do. We don't have to have any information about the partner. So can my Connecticut colleagues share what they do?
Hi there, this is Rayanne.
Hi, Rayanne.
Hi. So I work for Planned Parenthood of Southern New England. I'm not sure, I didn't do my homework before being asked this question, whether it's regulated by the state to include allergies, but we do inquire. We do inquire for our patients at Planned Parenthood if if they know if their partner has allergies. And back a while ago when I was writing paper scripts, I would write on there to the pharmacist, please check allergies if it was the partner's name on the script. But now we call the EPT in on the phone, and you could leave a voicemail saying, please check the allergies of the patient. So I would do that sometimes.
Correct me if I'm wrong, Rayanne, but you don't even need dual identifiers. Meaning, do you necessarily need to know the partner's name and date of birth?
Kathy, I'm just going to jump in really quick, because actually in Connecticut, we do have a requirement that the patient's name be on, or excuse me, the person's name, so the
Partners.
partner's name would need
Okay.
to be on the script.
Okay.
We, that's something that is bound by regulation. So that's something that I think, and I think we might have sent out some misinformation earlier this year on that. We did do some rechecking, and so we're going to be revising our advisory we have on our website, but it is required that the partner's name be on the script if that is going to be, called in or sent into the pharmacy. So I just wanted to add that. So sorry if Rayanne, you were going to be responding.
Yeah, Amit just put in the link to your advisory.
Yeah,
the chat.
the advisory is going to be updated. It just hasn't been posted on our website. That'll be done in a couple of days, but just wanted to make sure everybody is aware of that there was some misinformation sent out earlier.
Terrific. It
Great.
doesn't require you to check for allergies, though, to answer the original question.
Not that I'm aware of.
Yeah.
It would be very difficult for the primary clinician taking care of what we refer to in epidemiology as the index patient, or the patient in front of you, to know the entire health history of all your patient's partners. That's arguably not your responsibility. There are some gray areas, and we understand that. But I love Rayanne's approach, which is to get the pharmacists to help you a little bit, because they should be speaking directly to the partner. Every state and jurisdiction does it a little differently. I think you can hear that. But really, at the end of the day, I think you need to keep some first principles in mind. The first principle is simply make it easy as possible for the partner to access treatment, however you do it, within the bounds of law and regulation in your state. Okay. And that is only so that your patient doesn't come back reinfected. Okay.
Perfect, thank you. So for this one, where you got the MGen result, frustratingly, we had a vote for AF, doxy, followed by moxifloxacin. So let's kind of go through and see if we change our minds, if we keep the same thoughts. So MGen, just a quick recap, male urethritis, it's the frequency of MGen, it's more common than gonorrhea, but certainly less common than chlamydia. You can definitely be co-infected with both MGen and chlamydia. The typical case that I will often get called about is a patient with a phallus who has sort of recurrent persistent urethritis despite standard empiric therapy for non-gonococcal urethritis. Their chlamydia GC NAT is negative and they're having persistent symptoms. It's unclear whether MGen causes long-term implications like male infertility, other sort of anogenital tract disease syndromes. Pathogenic role in women is still being clarified. Remember that there were some MGen data in that PID study that I shared. So to make the diagnosis, for example, if you've ruled out other causes of recurrent and persistent urethritis, like you've sent your GC chlamydia testing, you've sent TRIC, it's not HSV, this is sort of at the bottom of your list. It's not going to be the most common, but does not grow very quickly on culture. There are not many labs that do culture. More and more, including at my center, we're now able to send nucleic acid amplification testing to Quest. There is a mycoplasma PCR, so there might be similar testing at your labs. And this can be sent from vaginal urethral swab or urine. Who should be tested? So you didn't order it in this patient with no symptoms. So thinking about what patients would I send it on? Recurrent NGU, like I just said, recurrent cervicitis, that and sort of looking at the data, that PID study, that makes sense that if they have recurrent cervicitis of unclear etiology, it could be MGen. NAT is the test of choice. Resistance testing is really not freely available in the US. It's only at certain research laboratories, and you really don't want to screen for asymptomatic patients, unlike for GC and chlamydia in certain patient groups. There is resistance increasing over time with this organism, particularly to macrolides. And these were data released in 2021 in the fall. And so our treatment regimen has changed over time. The first box is if you have resistance testing available, which I would say most of us, probably none of us in this group, have been able to have access to that. So the second box is going to be more relevant to the care that you give. So if you don't have resistance testing available, if your patient is symptomatic and you've ruled out other causes, the MGen-NAT is positive, the treatment of choice is the doxycycline followed by moxifloxacin. And the reason for that is that doxycycline really works on reducing the load of organism or the organism burden, and facilitates clearing the organism. In terms of follow-up, remember the test of cure that we have for other pathogens, the test of reinfection, not the same with MGen. So if you have asymptomatic patients, they got their treatment, they feel better, you don't have to do a test of cure. And treatment for partners, it's not very clear. We don't know if you're decreasing the risk of reinfection if you treat your partner. So consider testing the partner, or you can recommend it to the patient that their partner get tested and maybe treatment if positive. And then if you just don't have access to testing, you can consider treatment. So would anyone change their minds based on these data? Would people treat? Again, I did not circle a right answer because there isn't one. What would my colleagues do, Dr. Shu and Dr. Achhra? What do you think? I would not treat, only because this actually happened, so I can remember what I did. But in terms of, I don't know that I'm treating really anything. Was it just the MGen was an innocent bystander? And in this case, the side effects concerned me. But what would the two of you do?
Thanks, Zoon, and I'll quickly speak and let Kathy take over as well. But yeah, it is tricky, and I hope this is not a common scenario where we are getting the test results without asking for it. Hopefully, if that's happening commonly, we should address that with the commercial labs. But it is interesting because I did have a situation where someone was asymptomatic and was tested, and then they were referred to me because of some prior allergies. And the bottom line there was that the person thought this was an STI, found it very stigmatizing, and wanted the treatment regardless. And just yesterday I was speaking to a different clinician who said, well, we have some medical legal concerns if, say, they do end up having complications in future, and that may be the reason to treat. Again, I'm not saying that. So I personally would also stick to the guidelines of not going on treatment, but it may be in practice challenging. I think that some patients, when learn that it's a curable and an STI, then why am I not getting a treatment for a curable STI? And so it could be challenging. I see both sides here. So I don't know if I have a right answer, but I see both sides.
Mm-hmm.
Dr. Wangu, we actually have a comment in the chat. Ellen Strazzero shares, treat the partners of pregnant women. MGem has been found in placental cultures of preteen deliveries and cases of amnioitis preterm. Any comments?
Yeah, I think that's really interesting. And I think we won't have, I would be really interested to see more data as time goes on. I think in cases of pregnant women, when there's a question of we're not quite sure, our threshold to treat is even lower, and we spend more time on that risk calculation. And so that makes a lot of sense. Thank you for sharing that. I'm able to
Shu, what do you?
Yeah.
So.
There's another, I'm sorry,
yeah.
Go ahead, Dr. Shu.
Yeah, I'll just mention, thank you, everybody in the chat. I am able to monitor it because I'm not speaking. There are a lot of considerations, and I think it's a great topic for discussion because even when you look internationally, there's controversy about partner treatment and controversy about how to approach the treatment in general for MGen. So I think all of us clinicians who see patients with testing for MGen that we may or may not have been the ones to order it in the first place, but we are the ones left holding the bag because all of you are considered STI experts in Connecticut, and you'll sometimes get referrals, or patients will self-triage to you and say, oh my gosh, I had this lab finding, or my partner had this lab finding, what do I do? We're collectively scratching our heads. Literally in real time, you might want to put in an STD CCN consult. I think that resource has been given to all of you because that would reach one of us on call to work with you. Usually, unless the person is grossly symptomatic, has pus, you have a little time to think through this decision. And this is definitely an area for collaborative decision-making, okay? So reach out to one of us. MGen is a difficult situation. I understand many of you can find it, but association, remember, does not dictate causality. And there are many controversies, especially when you consider that some of the drugs to treat MGen have significant downsides. We actually literally got a call on a skater who was a partner, a figure skater, who was a partner of somebody who had MGen, but was no longer their partner. And so she was colonized with MGen, had no symptoms, and she heard about the use of a quinolone. She had already failed azithromycin and simpler courses of therapy. And the only thing we really had at that point was a quinolone to offer her. And we were not going there with her. She wasn't pregnant. Well, you wouldn't use a quinolone in pregnancy anyway, but do you see where I'm going? The quinolone arthropathy concern was that much more of something that you would need to weigh in. And these are sort of consult level good ID questions for many of us to talk about together. There is no recommendation right now to screen everybody with chronic BV for MGen. I just need to be clear with all of you that entering into the MGen world, just take one moment and step back with me. We have known about MGen for over 10 to 20 years, okay? And it hasn't been, it has been associated at times with preterm labor and chorioamnionitis. But the definitions of those anecdotes, when you go back to those cases, you need to look carefully to see that every other pathogen was also eliminated, because actually eliminating the other pathogens is really important. The pathogens that we know to be more tightly connected to preterm labor, and that treatment can interfere with the likely ensuing of preterm labor. Remember, in the BV world, we don't even treat everybody with BV, even though we know it's associated with preterm labor, because it turns out when we go to treat them, we can't stop their preterm labor association. It doesn't change it. Our drugs are not working for the purpose that many of us worry about. It's not necessarily the pathogens. There's something going on with the microbiome. So I need people to take a step back and understand the complexity of this situation, and association does not dictate causality, all those good things. This is a great debate. I do want Amit to move on to the next case. This case was multiplex, but I should probably make a couple comments on the trade-offs of the original PID direction you were going in. Do you mind? Can you all humor me? Okay.
Yeah.
All right. So I think many of you are aware, or the news is slowly getting out, that drug susceptibility for gonorrhea, we may not be able to count on cephalosporins forever. We have now announced the situation where in Massachusetts, we have identified through an amazing primary care clinician and frontline laboratory collaboration and a collaboration with CDC, we were able to identify a multi-drug non-susceptible strain of gonorrhea that's very similar to ones being published about in the UK. This is just the beginning. We are now embarking on a journey in Massachusetts that's specific to Massachusetts in making sure that our clinicians are more easily able to access culture and scale up on some initiatives that we need to do here now that we have publicized awareness of at least 2 cases. Because of that, and because of this being heavy on my mind, my insight into Dr. Wangu's case, the PID case, with this potential allergy to a frontline drug regimen, then devolves into, okay, so what happens if you do want to do something like levo? Or you are now aware that you should add metronidazole because the outcome microbiologically may be better for somebody with PID. That's what the Weissenfeld study really tells us. So now it's in the PID regimen that you should always include metronidazole. I would say that what this tells me now in 2023 is that we really have to follow each patient with PID. I saw more patients with PID during the pandemic than I ever saw before. It was very clear to me that screening for GC and chlamydia ameliorated many cases before we ever saw them. And then absent screening in the pandemic because we couldn't get people into clinical care for routine preventive medicine, I think anecdotally, certainly for my clinical practice, made a difference. I saw more PID. And with that, I gained more experience from my patients trying to tolerate these regimens. The toleration of these regimens is actually really dependent on us on the front line, nursing them through this. So the problem isn't that we don't know what drugs to use. The problem is that some of the patients really don't tolerate them well. Like 30, 40% of the patients will describe some element of GI distress. So how do you stack the deck of odds in favor of them tolerating the drug regimen that you know to be the best for them? I think there are other tools in our toolbox. These are not written about. This is not evidence-based. This is more at the anecdotal level. But we learned from our ER clinician colleagues that you can give a touch of Zofran. We learned this from our onc colleagues about tolerance of drug regimens and trying to help it with drugs that ameliorate GI distress. We learn this all the time when our patients tell us, hey, if I eat it on a full stomach after a meal, sometimes I do better. So all of these things will be really useful because we need to use these drugs until we get better drugs and better regimens. The other thing it really tells me is with PID, you have got to follow outpatient PID persons. First of all, how many times have any of you on the front lines ever prescribed a regimen and 4 days later you get around to calling them and they're like, I didn't get a chance to pick it up yet. Wow. And all of us collectively take a step back in ID, and I will tell you, outcomes are always better if you get the antibiotic in to treat the disease faster. So 4 days later, I hear from my patient they didn't get a chance to pick up the medication. Wow. I feel very anxious about these things, and I think developing better systems where additional colleagues of ours are supporting staff, check in with a patient to make sure that these things are filled. All of that good stuff is really important. Follow, follow, follow. And that will be my last message on PID.
Thank you, Kathy. And we'll definitely go back to allergy guidance a little bit later in the cases for some suggestions as to what you can ask your patients. And then also this exact question that I've gotten so many times, now that doxy is treatment of choice for chlamydia, I really miss my 1 dose of azithro and I'm really worried about it. So we'll review that in a little bit. So I'm going to hand it off to Dr. Achhra for the next case, and I will advance slides whenever you need me to.
Great, thank you, Dr. Wangu. And yeah, I think, even if we don't go through all the cases, as you said in the chat, Dr. Wangu, we'll send it out. But I think this discussion is where really the money is. So that's good. So hopefully we'll continue that. And if we don't go through all the slides, that's not a stress. 21-year-old trans female presents to your clinic for her first visit for evaluation of a newly diagnosed HIV infection. She was diagnosed 2 months prior, at which time she was also diagnosed with syphilis of unknown duration and got 3 shots of bicillin. She reports 3 cis male partners in the last 12 months. Last contact was 4 months prior, where she had unprotected oral, rectal, and penile exposures. Her main complaint or chief complaint today is a mucoid discharge on the stool and intermittent rectal bleeding for a while, as well as tenesmus. Yeah, next slide. And here are some of the pictures on your exam. You see that on the speculum, you see some mucoid discharge and inflammation, friable mucosa, as well as the swab showing the discharge there. Okay, next slide. Yep. So at this stage, what would you do? What test would you perform? Would you do the gram stain and culture, including the GC culture of the triple sites? Would you do the GC chlamydia NAT of the triple sites? Or would you only do urine? Would you send the LGV serology and genotyping test, or some combination? Again, so I open up if you want to speak up or put in the chat. And I think the next question would lead to the obvious question of what would you empirically treat for it as well. So think about that and answer. So triple site GC NAT, that's a good answer. Okay. All right, that's good. We can go to the next slide. So I think that's I'll touch upon the question about LGV in a little bit. And how did you empirically treat here? If assuming they have no known allergies that should be concerning. A variety of options here. Would you want to wait? That's an option because these are chronic symptoms. Or would you want to treat today and while wait for the results? And in that case, would that be ceftriaxone with azithro or a ceftriaxone with doxy for 7 or 21, and then or something different, basically. Someone said C. Sari Berg, do you want to tell why C? What are we trying to treat here?
I would be treating for gonorrhea, chlamydia.
Okay, that's good. Well, I guess I'll keep moving here. Next slide. So the question here is about rectal chlamydia and what do we know what works and why not a Z0 first question. And so 2 major studies came out, especially for the rectal chlamydia, and that's what led to the change in the CDC guidance as well. And both of these were trials, randomized trials, and essentially told us that doxycycline was significantly superior in achieving the cure versus what used to be in good old azithromycin kind of single dose. So much more 7 days of treatment, much more treatment here, but much significantly higher rates of cure. And so then, and next slide is the bigger message here is that even in the context of expected imperfect adherence in the real world use, the current consensus is that we should be doing the doxycycline, especially for rectal chlamydia, if not for all chlamydia. Okay, next slide. Yeah, so as I was hinting that, yes, the compliance standpoint somebody is mentioning here. So yeah, azithromycin was better in that sense, and don't forget more adverse effects from doxycycline for 7 days. That can be, can easily see, esophagitis and photosensitivity and so on. So you have to make sure that we discuss those things with the patient. Review the potential side effects, tell them the benefits, ensure the way of reaching you in case of the issues, because here again, you're not doing one and done, but you're giving them prolonged treatment. And so they need to reach out to you. Hopefully they have a way to do that. And so that brings those implementation challenges as well. If you're doing this on the go, on a bus, for example, then you would have the difficulty of having them linked to the care afterwards as well. Pregnancy is also a concern, and you're right. So that's when you will probably have to think about alternatives. Okay. The other question here is, well, in someone who has, who is a man with penis and has a partner who has vaginal sex, who is positive for chlamydia. So this is a situation. So in other words, if this is not a rectal situation, then maybe you could consider azithromycin. And again, it is mentioned as an alternative treatment. I think the next slide shows that. If you can go to the next one. All right, keep going. Well, I'll go to but bottom line is that azithro is an alternative, which you may consider in certain situations, but you know, I think generally speaking, the doxy is the big one. But the question that does remain in this case is whether it's 7 days or whether it's longer, and I'll tell you why. So this patient had the RPR of 1.1 to 4, so it's a good response to the prior pre-treatment RPR of 164, and had the oral and genital GC and CT were negative. So test results are positive for the rectal chlamydia, as you were already suspecting, and they were negative for gonorrhea.
Dr.
So, yeah.
There was already a comment from Ellen who weighed in earlier and had already, I think option D is the longer doxycycline course.
Okay, yeah.
I'd
So
love to hear her thinking.
Exactly, I was going to say, yeah. Let's touch on that.
What even earlier in the course of this discussion, Ellen, what made you consider this trade-off of a shorter course versus a longer course of doxycycline? What pushed you in that direction already?
The proctitis and the tenesmus. If you're getting, I was advised that if there's those symptoms, you want to carry it out longer. And again, the added bonus is if there is syphilis present, you're going to start to see a therapeutic effect usually with doxy. And for those who are allergic to penicillin, the extended treatment of doxy is the treatment for syphilis. I did see someone comment that it's really hard to get compliance with 21 days. And that is true, but every extra day, if you can get somebody to keep taking it, is going to be beneficial for a multitude of reasons, in my opinion, as I have been advised.
Right. So you actually started from your thinking driven by the physical exam findings, right? And that's really helpful to clue us all into that. Thank you. Keep going.
That's important because, we know that not many of these people could return for follow-up or may not even be reachable once you have lost that chance of giving the first treatment. And so it's a great thought. And I think where this is leading to is this question of when and how do we know about if they have LGV, lymphogranuloma venereum, which is what probably is also Ellen hinting to the reasoning for the longer course. So would you at this stage go to the 3 weeks treatment as Ellen suggested, or would you just do as you originally planned to do 7 days, or would you send the additional sampling for LGV, either prior sampling or the new sampling, or the combination of any? The next slide. So I think that the bigger picture here we are trying to say is the LGV, and so someone said E. So LGV is a variant of the chlamydia trachomatis serovars. So it's a serovars of L1, 2, and 3. In the West here, we have not seen it as commonly before. It has been endemic in some parts of the world. But we are seeing more and more outbreaks in the MSM, especially in the United States and other parts of the world as well. So the genital exposure is thought to be the transmission, and genital ulcer or a papule at the inoculation site, which usually resolves by presentation, but then you might get a unilateral painful inguinal adenopathy, as well as rectal exposure has been associated with proctocolitis, which can present this the way we just said in our recent case. And then the late disease could have more complications, which is also something we are concerned about, which could include strictures and lymphedema and infertility and so on. So it can be a very devastating disease, although not always symptomatic. So it can be asymptomatic as well. The big message here, yeah.
I have seen multiple surgical drainage of abscesses of the rectum that were done, and the gastroenterologist, they were MSM folks, and they may not have admitted that to the colorectal surgeon or the GI. Multiple times I've seen that post-op, and the GI did not do a GCCT culture of the rectum. And
Good point.
I've called and said, you might want to say, do this, but then I end up catching it post-op because the
Because they're
person
still
is still
positive.
having pain and drainage. So it's, it's surprising what other specialties might miss this, but I have found a lot of times if there's been surgery of the rectum to drain any abscesses, that you will find a chlamydia is the culprit. It's more likely to make an abscess, be more silent and make an abscess, I have found, than gonorrhea, which is more purulent and obvious, doesn't seem to make as many abscesses, or is treated better or found sooner. But chlamydia in the rectum, I have found, tends to percolate and sort of stay there and cause more permanent damage. But again, just a clinical finding.
Thank you. That's great. And a very important point. We don't see all STIs ourselves. So you're right that other providers should be aware and have some, depending on what sites they are entertaining. I've seen a lot of referrals, a lot of ophthalmologists, for example, who had not done RPRs and have treated syphilis with steroids and stuff. We've seen that too. Yeah, so I think another bigger picture here, which I think Ellen was hinting to already, is that LGV cannot be tested easily in our country here. And there are tests available, but they are not easy to access, and it takes time. These are serologies, which may not be perfectly reliable. And so the chlamydia test that you order routinely, the NET, does not distinguish whether it's a chlamydia different CROR or whether it's the L1230R. And so therefore, the only way for you to know is really either clinical, but mostly it's a clinical picture and some sort of prior contact and stuff, but really it's a clinical decision. So so far, I think the practice, as you already said, Ellen, has been that if you have clear proctitis, symptoms of proctitis, as our case here, and if they are chlamydia positive, you can basically treat for LGV, on going on the higher side, because we cannot be certain by our current diagnostic testing if there is LGV or not. So that the right way to do here would be to do the 21 days. Any comments or anything before we keep moving? Right. Hey. Yep.
Maybe just that because testing is so hard to access, don't get hung up exactly this on the diagnostic. It's impossible for many of us on the front lines of clinical care to get the tests that would tell us that LGV is present in real time. So the guidelines are constructed in such a way, if you go back and read them, you don't need to know that it's definitively LGV. If the symptoms are worse, or there's evidence of ulceration or local adenopathy, or progression that's a little bit more locally invasive, as Ellen just mentioned, go for it. Like go ahead and sort of really coach your patient that it's your opinion that 21 days is going to serve them better in the long term than 7. Amit, are you going to, Dr. Achhra, are you going to show them the fact that doxy and azithro are actually sort of equivalently poorly tolerated, that NEJM graphic? I didn't want to.
I wasn't planning. I don't believe we have that slide, but
No, not that specifically, but
yeah.
very
Okay,
true.
so let me just comment that when they had to do the head-to-head trials, and I saw the worry that we collectively have as clinicians, oh my goodness, our patients aren't going to tolerate these regimens. Yeah, they're not great. Already talked about that. How to solve it, do an end run around it with, a little Zofran support, some food, etc. But it turns out, I just want to be clear, that single gram of azithro compared to doxycycline for a week, when they competed it out in placebo control, it turned out the azithro was worse. The patients were blinded to which one they got. having said that, both azithro and doxy, it was like a third of the patients were really not happy from the GI standpoint. So it is what it is. We'll get better with our drug regimens, but we got to support our patients in the meantime.
Yeah, great point. Okay, next slide. So an asymptomatic HIV trans female discloses unprotected, insertive and receptive anal sex with a new partner. And what would you recommend? And so again, the options here are urine, GCCT, urine and rectal, or HIV, syphilis, plus minus Hep C testing, and a combination of the above, or none of the above, if knowing that she's asymptomatic. Okay, if you take us for E, which is urine, GCCT, and HIV, and others. Okay, a lot of E's there. Okay, keep going. That's good. So I think perhaps I'm preaching to the choir, and that's the case. That's good. But the bigger message here is that just doing the urine testing, which we commonly see, at least in my setting, I see commonly, for example, in urgent care and ED providers and stuff, and other settings where they are not used to taking care of STIs on their day-to-day basis, that they don't often do the urine, the non-urine, so the throat and anal orifices. And so that this slide just tells you that the amount of infections that you would miss if you only did the urine. The blue there is the ones which would be identified, and the whole red patch is the one where you would miss those cases if you didn't do the non-urethral sites. So sexual history and testing is important. So your patient has a positive, the one that we just mentioned, asymptomatic person, had a positive rectal chlamydia. At follow-up, she mentions that she was recently exposed to a toddler who with pertussis while she was babysitting them. And so she already received 5 days of azithromycin as a prophylaxis, post-exposure prophylaxis for pertussis because of that contact. The question here is that azithromycin that she got, is that sufficient for her rectal chlamydia, or must she get doxy as well? Any thoughts here? It's a twisted question, but I guess we're trying to touch on the azithromycin issue here. Okay, doxy. Anything else? All right, can proceed, Zoon. So as I wanted to mention before as well, that doxy is an alternative, although not in this fashion. So the RCTs of 5 days of azithromycin have not been performed, but there was these studies from Norway where they were treating the MGen actually, who also had chlamydia. And most of these received doxy, but there was a subgroup of people who received azithromycin. So it wasn't a perfect sort of a trial here, and there's a reference, but there was a subgroup of people who got a few days of azithromycin for the co-infection of MGen with chlamydia. And I think next slide. And what they found was that they had not bad response. Among there were most people actually did okay. There were 6 people who had positive on test of cure, and some of them were reinfections, and only 1 was a treatment failure. And so the bigger picture here, although, is that it's not a preferred option, but azithromycin either as a single dose or a 5-day regimen could be an option for some select cases.
Dr. Achhra, which 5-day regimen are you talking about? Are you talking about the 500, 250, 250, 250?
Well, let me step back. Dr. Wangu, do you know the regimen that they used in this study?
Yes. Yeah, I believe that was the regimen in this study.
Yeah. The 5-day, the
ask,
yeah.
Because collectively, people are getting really creative with these things. Some people are using higher doses of azithro for longer. A number of you commented that, doxycycline is still not FDA approved for use in pregnancy, right? So we prefer not to use it in pregnancy. By the way, if you had a patient with Rocky Mountain spotted fever who was in the ICU, who was pregnant, they would be getting doxycycline. Okay, so I just want to be clear that the doxycycline issue in pregnancy is really related to trade-offs, and we really prefer not to have any possibility of tooth staining in anyone not born yet. So there's complexities about the rules, and it's nice to sort of unpick the evidence behind the rules together. Just getting back to this, so a pregnant woman is particularly difficult to eliminate chlamydia from. There are a number of studies that have observationally watched cohorts of pregnant women, and that single gram of azithro is most likely not doing the job. These are still observational studies, so we need better studies always. But I think there's some concepts around treatment where people are using the 1 gram intermittently. They may be using 1 gram for several days in a row. And when you individually consult with us on STD-CCN, we're going to get really creative with you on the front lines, depending on the exact profile of the patient in front of you. When you have a more complex case, like pregnancy and chlamydia elimination, where you are going to be getting a test of cure, you are supposed to 3 to 4 weeks later, and you'll often find that they haven't eliminated the issue. Not our case here, but I'm just going to tell you, give you a heads up, don't be surprised when we do astonishing azithro regimens.
I like this one. So take home points, always consider the LGV in the differential. And again, we don't have a test. And so proctitis and MSM is a classical syndrome. And anyone who essentially is having unprotected anal sex is a classical clinical syndrome where you would perhaps consider empirically treating for LGV in the absence of any testing in particular, but certainly the chlamydia NAT that we routinely do should be positive. It just won't tell you which kind it is. Extra genitals, extra urine site, urethral sites screening, as we mentioned. The LGV requires 3 weeks of doxy and not the 1 week typically. Yeah, first line for chlamydia is doxycycline, but already as mentioned, so some cases you may need to wiggle with azithromycin if for any reason you cannot do doxy or otherwise. So I think that's the end of it. And yeah, any questions, or we kind of keep pushing through?
I think we have time for one more case.
Okay, great. I was just commenting to Linda that I think we have a couple minutes left, but I'm sure I can speak for Dr. Shu and Achhra. This is too much fun, so I'll be sad when it's over, but let's see how far we can get.
Yeah.
So this case, 35-year-old cis male coming in for a physical. The only thing he tells you is that he has some neck pain and his throat feels funny, but he can't quite explain it further. He says his last sexual exposure was about a week ago, unprotected, insertive and receptive, oral and anal sex. I'm going in the wrong direction with cis men and trans women. He uses condoms with his current partner, who's a cis male, only for anal sex. Past medical history, he did have chlamydia last year, urogenital chlamydia. For the allergy piece, he describes a rash he was told he had as a toddler to both penicillin and cephalexin. No meds, no substance use. And the only thing on your exam is you find several anterior cervical nodes that are tender. So with that information, which tests would you perform for this patient? So you can do your NATs for GC chlamydia at the throat and genital sites, NATs for GC chlamydia at those 2 sites plus rectal site. Do you want to do a throat culture for GC, just a urine NAT, or some combination of culture and NAT? I think I can open my chat window. So we have a vote for B. Any other thoughts? B, we're liking B. Okay, great. So keep that in mind. So this is his clinical course, and this is a real patient from one of our colleagues at the New York City Department of Public Health. So the original gonococcal gnat was positive at this visit after this patient came in with his neck complaints. Visit number 2, when the patient was called back because of the positive gnat, a culture was sent, and because of his allergy history, he was given an alternate regimen of an intramuscular shot of gentamicin plus oral azithromycin. That culture turned out to be positive. He came back for a 3rd visit for a follow-up, and his pharyngeal gnat for GC was still positive. He was called back again after that, turned positive. The gnat at that visit plus another culture was sent. Both of those turned out to be positive. Susceptibilities were able to be obtained for this patient on the GC that grew in culture, and it was actually susceptible to ciprofloxacin in this particular case. And at the final visit, both the gnat and the culture were now negative. So why was this case of pharyngeal gonorrhea so hard to treat? Why didn't the gentamicin and azithromycin work initially? And also, how would we approach his allergy history? What might be helpful? So Dr. Shu mentioned this, and I'm sure many of you have seen this in the news. So we sort of take this into account when we are talking about this case. In this case, susceptibilities were able to be sent, and a fluoroquinolone ended up being a good option. So recall that the current treatment guidelines, including the cases that were identified in Massachusetts with reduced susceptibility to ceftriaxone, both of them were successfully treated with the single 500 milligram dose. You go up to 1 gram if they're over 150 kilos in weight. And then, of course, your additional chlamydia testing will guide whether you add a second drug to that. But we no longer recommend, CDC no longer recommends dual therapy if GC is the only thing that's diagnosed. So again, this change was based on a couple of things, including antimicrobial stewardship, the impact on both of these therapies, and of course, resistance over time. The important thing is that, let's say you need some treatment alternative for an anogenital infection. So we have cefixime. It used to be lower dose. It's now 800 milligrams. And then, of course, add on your second drug if you haven't answered the chlamydia question yet. The important piece about cefixime compared to ceftriaxone is that we know the levels in the blood are not equivalent. The second thing is, in addition to that, there's really, cefixime doesn't work well for pharyngeal gonorrhea. So what's so special about the pharynx? Why is it so hard to treat pharyngeal gonorrhea? We'll get to that in a second. I just wanted to mention, remember, our patient had the rash to amoxicillin and cephalexin as a toddler. He's now 35, and he got gentamicin and azithro. So what is behind that? Why is that a regimen? So data from 2014, where 2 regimens were looked into, gent and azithro, like for our patient, gemifloxacin, azithro. There is a shortage in the US of gemifloxacin, so I haven't been able to get it successfully ever. And the bottom line, pun not intended, is that the trial was not powered for extragenital gonorrhea. There happened to be a few patients for whom this regimen worked, but really, like Dr. Shu just mentioned, the efficacy was limited by tolerance. So 1 gram of azithro is relatively hard to tolerate. 2 grams is beyond. So a lot of these patients vomited the whole thing anyway, and they needed ceftriaxone and azithro in the end. And remember, these patients, they didn't have cephalosporin allergies. These data were just used to inform what we might do if a patient has a true cephalosporin allergy. So as part of the 2021 guidelines, this was released a smidge earlier, I think. Gent and azithro combo is an option for your genital and rectal gonorrhea if your patient has a true cephalosporin allergy. But what about pharyngeal infection? So the very special environment, why is eradication more difficult here? There could be a couple of reasons for this. There have been some more data about this. For example, when we measure PK/PD, pharmacokinetic and pharmacodynamic data, are the drugs not reaching the pharynx? I think that's actually not the case, but something is happening beyond that. So is there something different about the immune system? Or all we know is that drugs just don't get to the pharynx the same way they get to the urogenital and anal mucosa. There are no reliable alternative treatments for pharyngeal gonorrhea apart from ceftriaxone, and treatment failures are common with that gent-azithro combo. So if your NAT is positive and you are concerned for a true allergy, always first call your Connecticut DPH team for guidance in terms of, do I need to get a culture? If so, how can I get it? Where does it go? And you heard about that earlier today. And then, of course, if your patient is not miserable, if they have mild or no symptoms, have the discussion with them about, this is what we need to do. These are the steps. You can defer treatment until you do have those susceptibilities, rather than perhaps give them a regimen that you know has a high treatment failure rate and expose them to additional antibiotics with all of these concerns. On that, a word or few on penicillin allergy. So again, 35-year-old with this history of some sort of rash when he was a toddler. So how do we weigh that at the visit? Can we really not give ceftriaxone, which we know is going to be the most effective for pharyngeal GC? So fun fact, 10% of the US population reports having a penicillin allergy, but really only under 1% of the whole population really has a true allergy. And I think someone had mentioned earlier, if you have sort of a mild reaction to an earlier generation cephalosporin or a penicillin, typically our patients will very easily tolerate a later generation cephalosporin like ceftriaxone. If it's a more severe reaction, if they describe having symptoms that sound more like anaphylaxis, of course, you wouldn't give it. You would need further evaluation, including if they've had reactions like that to penicillin before you use a cephalosporin. So a lot of good impact from correctly identifying truly allergic patients, especially in this era of resistance and GC. Some questions that might be helpful. And I find that if I ask sort of even just what the reaction is, because many times in our system, the allergy will be listed, but not the reaction. And I would say in 90% of the patients are asked, well, what was your reaction? Oh, I had diarrhea. And I'm kind of thinking, well, who doesn't? So, you know, diarrhea with antibiotics is pretty common. And sometimes you can clarify that right off the bat. But sometimes this might help to make you feel more comfortable saying, oh, actually, that's not a reaction that I'm concerned about. And now I feel comfortable giving this antibiotic that I know will be much more effective.
We actually have about 3 minutes.
Oh, good. Right under. Any questions on that at all? Okay. Should we try to do, oh, no, backwards. Ignore, you do not see that.
Yeah, maybe we can spend time to see if people have comments or questions on this case. The pharyngeal, I know, I just was going to mention, this might sound silly, but there were multiple trials on mouthwashes, especially the Listerine and the pharyngeal gonorrhea. And I don't know if you know details. My sense is that they didn't pan out, either weren't effective or weren't effective enough, or I don't know if you know anything more about that. But just local treatment essentially with the antiseptic.
Yeah, I mean, I do remember talking about those data with Kathy, and several of my patients actually brought it up in visits with me saying, oh, I'm just going to gargle Listerine all the time, like before sex, after sex. So, it's interesting. It's not enough to make any sort of recommendation, but Dr. Shu, do you have any other comments on the?
No, I heard very similar things. The problem is we don't know long-term impacts on microbiome, and the bugs are infinitely creative. Just everybody remember, you can gargle twice a day with Listerine, but man, the stuff that grows around your gums, it comes back in like seconds, minutes. These bugs like really multiply very quickly. So what it does with gonorrhea, I'm not totally sure yet. Our Australian colleagues were the ones behind that study and others. I think there's a lot more to come because we are entering an era where we're not going to be 100% certain, maybe only 95% certain that ceftriaxone really does work in the vast majority of individuals. And I just want to point out that multi-drug non-susceptible gonorrhea in 2 cases in Massachusetts, neither of which broke through the current ceftriaxone dosing regimens. We need to be clear, that's in the public clinical alert. I'm not releasing any information to any of you that I haven't been able to disclose publicly. We are coming out with a paper, we will explain ourselves more, okay? But that's why we're not changing treatment guidelines. That's why CDC is not overreacting and changing treatment guidelines. We need to think of public health considerations as something measured in response, fast response to situations. And I think it's incentivizing creativity in the scientific and clinician community taking care of gonorrhea patients to think about, gee, maybe it's not just a single dose I need to give anymore. Gee, maybe I could use a different drug, an older drug. I've never thought about this drug in the longest time for something like this. Hang on, don't go into the Wild West yet. Don't go inventing things. It's okay. Use the 500 of ceftriaxone or the 1 gram if the patient is heavier. It's okay. It's okay. We have time. The Massachusetts cases are a warning, and we had to stand up our clinical and surveillance capacity in Massachusetts. Other states in the region are considering carefully what to do as next steps with their clinicians, with their systems, what's possible. Okay, so no one panic. It's okay. We have time. We can do this. Deep breath. Understand that I'm also coaching myself right now because literally I'm in the midst of hundreds of conversations on this right now because it's such an incredibly hot topic. We all knew this was coming someday.
Yeah.
I just want to say thank you so much.